But you can't have.
I think today we have a topic that
Right.
ought to be of a great deal of value because it's something I understand absolutely nothing about. To be very honest. And this is the coming thing. Whether we like it or not, I think warfarin is going to disappear. Yeah, I think it is.
I think that is the market, as we see more and more adverse events, and I love the fact that you watch the golfers talking about how they can eat anything they want, and all they have to do is take their Xarelto. And the very next commercial is, if you have taken Xarelto and you have had please call. So I've been tempted to write an op-ed for the New York Times.
We will.
This would be one of them where juxtaposed you have an advertisement and then a lawyer saying, call me if you've taken just what they talked about. So
anyway, my supposition
learn
is
about this.
that warfarin is going to disappear.
We won't spend too much
Whether
time
we like
on
it or not. But anyway, we appreciate this because this is one of the things that, like I say, I know nothing about, and every time I try to approach it, it just confuses me more.
All right. Well, we'll try to fix that. For those of you who don't know me, I am Ashley Sadowy. I'm one of the pharmacists here. You may see me in the ER from time to time. That's where I spend about half of my time. So today we're going to look at some of the new stuff that has come out recently, or maybe a little less recently, for our oral anticoagulation. I have unfortunately nothing to disclose to you today. As far as learning objectives go, we'll spend a little bit of time looking at the direct-acting oral anticoagulants themselves, their mechanisms, and then some various pharmacokinetic and pharmacodynamic characteristics that'll play a role when we talk a little bit more about reversal. We'll review the existing reversal strategies for oral anticoagulants, and then we'll discuss some of the stuff that we might see here in the future, next 5 to 10 years or so. So just to go over our outline a little bit, we'll kind of treat it as almost a timeline, for instance. We'll start with a little bit of our anticoag review. We'll do a little bit of warfarin just to get us all back on the same page so that we can talk a little bit more about reversal strategies. We'll look at what we used to do. We'll move into the direct-acting oral anticoagulant era, and then from there, we'll look at some early reversal strategies, our current recommendations for all of these oral agents, and then we'll see what we have coming up in the future. So to start, we won't spend too much time on this because I think we're all fairly familiar with the clotting cascade. But we'll use this diagram throughout the presentation so that we are all on the same page and see where all of these are acting, and we can use it as a visual because I'm very much a visual learner. So the intrinsic and the extrinsic pathway are our two initial pathways. Where they converge would be the common pathway here at the 10A. If we go back to, if we go to the intrinsic pathway, I want to point out here that this includes factor 9. It will be important as we move forward. When we look at the extrinsic pathway, that will include factor 7, which will be very important as well. And then in the common pathway, we'll focus on factor 10 and factor 2, or thrombin, or 2A thrombin. So just so, again, we're making sure everyone's on the same page here. We all know that patients are taking these oral anticoagulants for various number of reasons. They might be treating or preventing a DVT or PE, or preventing stroke. So that'll be kind of important as we go through with some of this, just to keep in mind our risks and whatnot. Yeah.
One thing to add to that, which is an enormous percentage of the population my age and older, is patients with coronary artery stents. A coronary artery stent placement bills, the cardiologist gets the same as a cardiac surgeon who splits a sternum and does a bypass using vein graft. And those stents, even drug-eluting ones, require oral anticoagulants. And so that's the enormous part of the population. That's a very big population that's taking these drugs.
Okay.
So
a lot of these ones that we'll talk about later won't have that much to do with it. They don't have those indications, but that is something that warfarin has been used for. And then just keeping in mind, we're talking specifically about the oral anticoagulants today. We're not really going to talk anything about parenterals, mostly because we're going to be focusing on the patients that are on the outpatient side of things. They're taking these every day. They might come in for a bleed or a traumatic event, etc. So we're looking just at oral. In addition to that, like I said, people might be coming in because they have a bleed or they have a traumatic event, but we also might need to reverse patients' oral anticoagulation if they need to undergo an urgent procedure that might have a high risk of bleeding. So my first thought here is cardiac procedures, but there's definitely other ones, and that is not my area of expertise whatsoever. So that's something else to keep in mind when we're talking about this. The main point in when you're considering reversal to consider is the risk and benefit. There's really no clear-cut guideline of when you need to reverse something versus when you don't need to. A lot of it is going to come down to would the patient benefit better from being not anticoagulated, because remember they're on these agents for a specific indication, either so they don't clot or they don't have a stroke, etc. And the other thing we'll talk about a little bit with some of these agents that's not necessarily pertinent to all of them is if we do reverse them, their anticoagulation, we might have to worry about prolonging their time to re-anticoagulation after the event. So all things to keep in your mind when you're considering the need for a reversal or not. And I mentioned a little bit about these spontaneous bleeds, and we all know they're not necessarily spontaneous, but when we're looking at some of the major studies that got these drugs their indications, we have to take into consideration their bleeding risk that is associated with them. So if we look at the main categories here, major bleeding, GI bleed, intracranial hemorrhage, and fatal bleeding, what you can see from the three agents, and we'll talk about them a little bit later on, they all have a varying degree that was reported in these studies. And now granted, keep in mind that these were their initial studies. This is not the post-marketing stuff that we have been hearing about a lot more lately with increased risk of bleeds. But just to overall summarize these, the risk is generally similar to that with warfarin or less in some of the scenarios. So anywhere in the less than 0.1% range all the way up to about 3.5% was the initial bleeding rate that we saw with the majority of these agents when compared to warfarin. So it definitely does happen. We've all probably seen it at this point. We'll take a step back and we'll first talk about warfarin for a little bit, just so that we're all on the same page again. We've been using it for nearly 60 years or just over it, and it's very widely used, as we all know. It's one of the leading causes for emergent hospitalizations among many older adults. And again, our indications are just what we've talked about already. Mechanistically, it is a vitamin K antagonist. So our factors 2, 7, 9, and 10 require vitamin K in order to become active factors, and also protein CNS require vitamin K. So if we are inhibiting vitamin K, the liver can't actually make these factors. And we all know dosing is completely patient specific. So that requires a lot of laboratory monitoring and all sorts of fun things. So if we're looking back at our clotting cascade, visually here we can see warfarin acts in each of the pathways. So we have a little bit of action in the intrinsic, the extrinsic, and then 2 spots where it has functions within the common pathway. So remember 2, 7, 9, and 10. Obviously, we're all very aware of many of the disadvantages. It does have a narrow therapeutic window, so we have to get their dosing just right, or they could bleed, or they could clot. So we watch the INRs for that, and that does require a lot of laboratory monitoring and all sorts of awful things like that. There's also a wide variety of dosing ranges that you might see a patient on. If we had 15 patients in this room right now, they might all be on 15 different doses. That is also subject to various genetic variations. So you might have some that we know about and we can monitor and adjust their dose for. Some we might just not know about, even 60 or so years later. The other main thing is drug-drug interactions are huge with this, as well as drug-food interactions. We're always telling patients, monitor your diet, make sure that you're very consistent with what you eat, especially those awful green leafy vegetables. So lots of disadvantages to using this. So it only makes sense that in the future we're trying to move away from that. We'll talk a little bit about early reversal strategies for warfarin, because that kind of got us to where we are now. Obviously we can use blood products. We'll talk about vitamin K, and then we'll get into some of the factor products that we've either tried throughout the years or we are currently using today. Obviously, we're all completely aware of what FFP is. It contains all of the blood factors that are found in human plasma. So it's going to definitely have that 2, 7, 9, and 10 that the warfarin is inhibiting, but it's going to have all the others as well. And it's going to be a larger volume. So I use the example here of a 70-kilo patient that's going to require about 4 units of FFP, let's say. And that's only going to raise their plasma factor level roughly 10 to 20%, depending on which resources we're looking at here. So there's definitely issues with giving someone that amount of volume. We have a lot of patients that have heart failure, renal disease, etc., and they just can't always tolerate that fluid replacement. Obviously, then there's a delay in time, so if we're using FFP, it's frozen to begin with, so we have to watch and think about the amount of time that it's going to take to thaw it, but then also administer it. So obviously not ideal there either. And then obviously there's some infection and infusion-related reactions to be considered of. So in all, blood products are not ideal. They're what we've worked with for about forever when it comes to warfarin, but not always the ideal scenario. Vitamin K, if we replenish the vitamin K sources, your liver is actually able to make those factors that it can't when warfarin is on board. Usual oral dosing is a little bit lower in the 5 milligram range, but when we get into talking about bleeding in urgent situations, we're not going to give someone oral therapy. We're actually going to, in this scenario, you're going to give IV. And I do point out here, it's important to give it as a piggyback because there has been risk associated with it in many, many years, many studies, et cetera, where patients have undergone anaphylactic reactions. So we definitely want to give it in a piggyback and give it diluted. And then we also avoid sub-Q and IM routes at this, in this indication because we'll get a more rapid and reliable response in the INR if we give it as an IV. So we don't have to worry about it distributing and whatnot. This is the main reversal agent that we can use where we have to worry about re-anticoagulating them later because the factors that the body is making, they each have their own half-lives in addition to the drugs having their own half-lives. So it takes some time for those to be repleted or depleted again after we try to reinitiate warfarin later if that is an option. So that's the main things with those. And then we move on to our factor products. So one of the first ones that you really started to hear about was a 3-factor PCC, or prothrombin complex concentrate. This contained factors 2, 9, and 10. So we're missing factor 7 in there. Unfortunately, this was actually never really available in the US, so we're not going to spend too much time on it. But a lot of our studies initially for the use of these agents come from this 3-factor PCC with or without the addition of an activated factor 7, which we'll talk about in another slide or two. So we could make a 4-factor complex, maybe with the use of these 2 agents together, but they were never available here in the US. PCC4, or Kcentra, I'm going to use some drug names here, don't yell at me. It'll be a little more easy to associate this with use, I think, if we use some of the names. This was approved in April 2013, so it's been out for a little while now, and it is the only product, and its only indication is actually for this, for the urgent reversal of a vitamin K antagonist coagulation factor deficiency that is associated with a major bleed or the need for an urgent therapy or surgery or procedure. So this contains factors 2, 7, 9, and 10, as well as protein CNS, so kind of makes sense that this is the perfect agent for warfarin, right? This is to be given in addition to an IV piggyback of vitamin K, and the thought behind this and why it was studied as such is these factors they can work really quick. It'll reverse your INR within minutes in most of the studies, but it's not going to last forever. So most of the half-life studies will give you about a 12-hour window where your PCC can work up to. Some are a little bit less than that, but that way you have the vitamin K on board so that at that 8 to 12-hour mark, your body is already trying to start remaking those factors. So it's kind of a 2-step process together. I will point out here that repeat dosing has never actually been studied with the use of Kcentra in this scenario specifically, but in any other scenario as far as I'm aware. So we don't really recommend repeat dosing. One of the major risks might be potentially thrombosis or something like that. But we just don't really know if it's safe or any more efficacious. So we don't really do that. The thing I will point out about this product, and this will come into play again later too, we don't really know the mortality benefit per se from the studies. So the studies looked essentially just at lab values. And it basically said that we can look at the INR and it's elevated, we give this drug, it's not elevated anymore. But we really don't know what that means in terms of patient. Obviously, we know that bleeding is usually pretty bad. If we're giving this, we might be able to prevent the bleeding a little bit, but we really don't know mortality, morbidity-wise, if this is any more efficacious than some of the other products. Laboratory-wise, it definitely works. Yeah?
Is the factor 7 in this moiety, is it activated, or
No.
is it the pro-molecule?
It is not activated. There actually is the next one. That's actually a perfect, we'll come to that in just the next slide. So I wanted to go over dosing a little bit because it does get kind of confusing. One of the unfortunate factors is we don't really know what dose to use without an INR. So it's important, and in most scenarios, we're going to get an INR to at least see where we're at with the warfarin anyways, if a patient came in and was bleeding, or if we needed to know if we needed something reversed before we go into surgery. So we get their pre-treatment INR, and if it's in the 2 to 4 range, we're going to use a lower dose of 25 units per kilo. If it's higher, greater than 6, we're going to use 50 units per kilo, but if it's in between there, we use a dose of 35 units per kilo. I also point out here that if a patient is greater than 100 kilos, we cap it out at the dose that a 100 kilo person would get. So the max dose that anyone could receive is 5,000 units. So let's say we had a patient that came in and he or she weighed 110 kilos. We're going to give, and they had an INR greater than 6, we're going to give them about 5,000 units of Kcentra or 4-factor PCC. That's going to run about $7,500. So these agents that we're going to talk about that are all these factor products, they are not cheap. So that's why it's important for us to know how to use them, when to use them, etc. So I mentioned a little bit recombinant factor 7A. We're not going to spend too much time on this, mostly because it really doesn't have an FDA indication for reversal. Using, factor 7, it's really only targeting that one area. None of the agents we talk about moving forward are going to involve the extrinsic pathway. And this by itself really wasn't super helpful at anything with regards to warfarin.
And just to add on, you're exactly right. There was a non-inferiority trial done looking at patients that had head bleeds on warfarin, and it was traditional reversal versus factor 7A. And in fact, what they found was there was increased mortality with 7A. The Canadian National Health Service has now put out a statement, I think in 2014, that said that basically outside the use of in hemophiliacs with antibodies, 7A has no role in the acutely bleeding patient, and even the military has stopped using it.
So that was another place that it had been significantly studied, was in trauma patients within the military. So yeah, this is not super useful nowadays. The other thing is that it is an active factor, so a lot of the studies were showing these morbidity and mortality increases. A lot of them were due to thrombosis because you're giving an activated factor. So the point that it makes here is originally it was used with those 3-factor PCCs, and now we don't really need any of that. So this was another agent that was originally sort of studied, not a whole lot of evidence for its use in any of our reversals, was the activated 4-factor PCC. So this one you might know as FIBA. Anyone? Again, not a lot of evidence for this use, but in case you hear these other terminologies, I wanted to make sure that everyone was kind of aware of what all of these meant. Again, we just talked about this. It is an activated factor 7 within this complex, so it's our PCC that we use today, but it has that activated 7A factor. And so that is where our thrombosis risk comes into play. So again, not super useful in today's world. So quickly, we'll go back to 2008. That's sort of where we are on our timeline. And at that point, we were trying to figure out what do we do with this warfarin. So these, I do want to point out, these are the old CHEST guidelines, and I'll explain later on why we're talking about this first. But if we look at this very, very bottom row, there we go. At any INR with any bleeding, basically told us what to do, which wasn't super useful at that point. They told us to give vitamin K and then give something else with it. But it didn't really explain what we were supposed to do. We didn't really know at that point. And the other thing to point out here is that we didn't really have any information then on what to do with these newer agents that were coming out. And that's actually because that was 2008, and we didn't actually start using the oral anticoagulants that are targeted therapies until a little bit later. So we'll get into our direct-acting oral anticoagulants. Some of you may have heard these as target-specific or novel, etc. Fun fact to point out here is that we no longer really recommend the use of the novel oral anticoagulant because no AC it was associated with a few incidences of patients not receiving anticoagulation because it looks like no AC. So we don't use that one anymore. But each of these agents has a selective inhibition mechanism within the clotting cascade. So whereas warfarin acts on 2, 7, 9, and 10, these will each act in one specific area. And we'll talk about each of the 4 agents as we go along. They're listed here. Advantages, they have that targeted mechanism. We know where they work. We know how they work. We can target one specific area. They have a much more rapid and reliable onset of action, whereas warfarin can take 5 to 7 days or so to get a therapeutic INR and actually achieve what we're looking for, but then it can take 5 to 7 days to get it back off. These are much more rapid in our ability to on-off them, essentially. They have much shorter half-lives to go along with that, and there are less drug interactions. There are still some that we have to be cognizant of and some dosing issues, but for the most part, much less than warfarin has always provided us. We have decreased use of monitoring parameters that we really have to look at as frequently. And one of the advantages, but it's also a disadvantage, is fixed dosing. I say it's also a disadvantage because if a certain patient population hasn't been studied, we don't really know what dose to give them because we don't have those laboratory monitoring parameters that we can actually look at. So that's an issue. Yeah.
I'll say something else and then I'll try to shut up. But
okay.
So one of the things that is someone who's spent my life studying these things is the decreased monitoring is advertised as being a benefit because nobody likes to get stuck in the arm.
Exactly.
But also
it's
recognize that the reason there's decreased monitoring is because there is no laboratory test that can adequately determine the degree of anticoagulation for these agents. So when you've got someone coming in as a trauma patient and they're on one of these agents, you're flying completely blind. You don't know where they are, and so it's a double-edged sword.
Exactly.
You don't have to get a lab test, and the reason you don't have to is because there is no lab test that will work.
Exactly.
So it's not necessarily actually a benefit. It's a drug company benefit that they use for advertising purposes, but for patient care purposes, it's really a liability.
Absolutely. Cost is definitely going to be a prohibitive issue with us here. And then kind of going along with Dr. Owings, we don't necessarily have great reversal and antidote options just yet, we'll say. So our first one that came to market was Dabigatran, and you'll see a theme to the majority of these. These agents will come to the market and they'll have one indication, and by the end of, up to today, they'll have multiple indications. So I won't spend too much time talking about that. Just be cognizant of your differences based on indications. This Dabigatran is unique in that it is the only reversible direct thrombin inhibitor, so that's going to act on factor 2A. So if we think back a little bit, we can think of where in the clotting cascade that is. It does have a half-life in the 12 to 14 hour range, so these parameters are all things to think about when we're going to talk about when to reverse, do we need to reverse, etc.
I think that's a very good point because a lot of people are saying you can wait for a head injury patient for like 24 hours it will be out of the system rather than having a knee-jerk reaction to reversal.
Correct, yeah. And that's one of the things we'll kind of talk about, especially with the Dabigatran.
Right?
Oh yeah, sorry. I'll try my best to use some of the brand names to get everyone back, but I might have to phone a friend for some of them. It is 80% renally eliminated, which will be important again later, so keep that in your mind. And it's only about 35% protein bound. There are some drug interactions that we have to worry about, and this This whole slide lists all of the data, or the dosing recommendation data. And I'm not going to sit here and read all of this to you, just pointing out a few things. It is a BID dosed medication, so that's, again, something to keep in mind when they last took their dose. Are they due for a dose now? How big is their bleeding risk if it's twice daily and they haven't taken it for 20 hours or something? So some other things to look at here, we have to watch for our ketoconazoles, our azole antifungals, which we'll have to basically watch for all of these agents. And then we have to watch using these agents in patients with renal dysfunction or end-stage renal disease. So definitely some things to keep in mind there. Our next one to the market was Rivaroxaban, or Xarelto. Again, it came into the market first in July 2011, and it's received a bunch of indications since. It was the first direct factor 10A inhibitor. So that's right where the common pathway begins, where the two intrinsic and extrinsic come together. Again, it has a very short half-life of about 5 to 9 hours. Don't let that one fool you too much, because it is usually, most indications will be a once daily dosing. It's less renally eliminated significantly than Pradaxa was, at only about 36%, and it is significantly protein bound. Again, this will all be important when we talk about a few more things. Like I mentioned, mostly daily dosing. You will have BID dosing early on for patients right after they have a DVT diagnosed, because that first 21 days, the study was conducted in such a way that we gave BID dosing at that point because of the higher risk for reclotting, and it got its indication in dosing. Again, we have to watch out for hepatic impairment here, as well as those same 3A4 inhibitors and inducer agents. So a lot of the main classes I think of here, again, are your azole antifungals, as well as some anti-epileptic drugs, just to keep in mind, and renal dysfunction as well. Okay, so our next one was about a year and a half later, so Apixaban, which is Eliquis. It also has all these indications, so we might be seeing it a lot in patients as we move forward. Again, it's the same mechanism as the previous agent. It's a direct factor 10A inhibitor with a relatively short half-life, again, about 8 to 15 hours. It too is not significantly renally eliminated, just under 30%, and it is significantly protein bound at about 87%. Again, we have to worry about hepatic impairment here and those same drug interactions that we've talked about. Dosing, again, it's a little bit different in the first 7 days for DVT here. Again, that's just how it was studied and got its indication. And here we have to worry a little bit more about some other issues. We have to look at the patient's age, weight, and serum creatinine. If any of those two are out of the normal range per se, then we have to adjust their dosing. But again, this is one of those that patients may be on daily or twice daily. So just things to keep in mind for reversal purposes. And lastly, we have Edoxaban. And this was actually, it just came to market a little over a year ago. It is the last of our factor 10A inhibitors so far. And it too has that same relative half-life in the 10 to 14 hour range. So again, much less than our Warfarin product has in regards to the inhibition of factors. It's a little bit different than the last ones in that it's 50% renally excreted, so roughly half of it, and again, roughly half of it is protein bound as well. So I promise you, I'm not telling you these numbers for no reason. Dosing again is actually daily for this one, which is nice for the patient and maybe not so great for us. But the other thing to point out is any patient that has really good working kidneys, creatinine clearance greater than 95, shouldn't be on these agents. So each of them has their own little tidbits that I don't expect anyone to walk out of here today knowing or memorizing, but just kind of being aware that these are things to keep in mind when we have patients on these. And again, there's some varying drug interactions to worry about.
That one's Savesa.
That one was Savesa. I forgot to tell you that. I'm very sorry. So putting it all back together, we can look back at our clotting cascade, and we see that Rivaroxaban, Apixaban, and Edoxaban all work on that 10A within the common pathway, whereas Dabigatran is its own little entity that inhibits thrombin over on 2A. monitoring, like we kind of said, it's a blessing and a curse. If we don't have labs that we can look at outside of normal renal and hepatic function panels, it's kind of a struggle to know exactly what we're working with, how anticoagulated is this patient, etc. Some scenarios, and we'll talk about specific labs that would be ideal to be able to obtain, but you're going to be monitoring coags on these patients, and some of the other things we'll talk about whenever there's major bleeding in the perioperative phase, any type of reversal when that is needed or completed, and then if we have an unfortunate suspicion of an overdose. So those are your main times where you're going to get additional labs on these patients. And I say that because we have all these coagulation assays that we're going to talk about a little bit, but you'll see, and sort of how Dr. Owings had pointed out, they're not super useful because we can't just get an INR and see where they're at. So the APTT is purely a function of the intrinsic pathway. It tells us how that's working. So if we think back again to the coagulation cascade, not really going to be super useful with any of these agents since they work on the common pathway. When we could get a PT-INR, but that is a functional assay of the extrinsic and the common pathway a little bit, and it specifically looks at factors 2, 7, and 10. So again, super useful for warfarin, not super useful here except for maybe our thrombin inhibitors. We can look at the thrombin clotting time, which is a direct assay of activity for thrombin, and we can look at the eccrine clotting time, or ECT, which is also looking at the functionality of thrombin and thrombin generation. So we have these two that are specifically for thrombin, but how many of you have ever actually been able to order any of those labs? Okay, you're excluded. So really, they're not useful because we can't actually get them. If we called the lab today, they would laugh at us if we tried to order these. And then we have a chromogenic anti-factor 10A level. We can get 10A levels per se, but again, these aren't super useful because would you know what to do with one if you got it back? Exactly. So we can look at them and we can compare them when we're doing these fancy little studies, but not super useful in the patient themselves. So putting it all together, it makes sense that our Dabigatran, it might be useful to look at the ECT and the thrombin time, but the other two, the PT-INR and the APTT, really aren't going to tell us much. Same with the Rivaroxaban or Apixaban. Those are working on 10A, so our anti-factor 10A might be helpful, but the others are not really going to tell us that much about it. So we have our early strategies. When these first came out, we didn't have any idea what we were going to do if someone came in with a bleed or needed a surgery. So we we looked back and we used what we could in our little artillery. We could potentially use blood products again, so our FFP could come into play here, but again, its usefulness isn't always useful, I guess. If we can't give someone that much blood, or we can't give it to them quickly, how good is that really going to affect everything? Again, we can look at some of our factor products, so we could consider some of these same ones we talked about, and then we'll look at specifically a new agent that has just come to market. So we'll skip straight to the factor products because the majority of studies, again, for what we have been doing up to today have been with these PCC products. Again, PCC3 with or without factor 7A, a little bit of studying has been done with these, but not useful to us here in the US. So we started looking at the use of PCC4 for some of these other agents. So we know that it's going to work on warfarin. We know that that's going to be all well and good. And what we did find when we studied it in healthy volunteers that were receiving Rivaroxaban, it did allow for immediate and complete reversal, per se, of the Rivaroxaban effects when we're looking again at mostly laboratory monitoring. But it really didn't have any effect on Dabigatran. So not really super helpful long term. And the question that comes up is, well, if we dose Kcentra or PCC4 based on an INR, well, the INR is really not going to be elevated, so what do you do? So most of the studies to date that have been looking at this have used the max dose, so the 50 units per kilo up to 5 1,000 units. Again, very controversial. If you read any protocols or any literature from a bunch of other facilities that have done anything with this, the dosing is kind of all over the board. But for the most part, a lot of people have been using that max dose just because, again, we don't really know what we're doing with these. And also, mortality benefit. Sure, we can make labs look all fancy, but what really happens to the patient? So just in October, I'm going to absolutely butcher this name as I usually do. I call it Idarucizumab, but it's actually Praxbind, and it makes sense because it was the reversal agent that came to market for Pradaxa or Dabigatran. It is a first-in-class IV monoclonal antibody that does bind to both the free and thrombin-bound Dabigatran. So all the Dabigatran that is pretty much within that patient's body, this can bind to. It'll also work on some of the metabolites that come from the Dabigatran. And it essentially works by neutralizing their effects. So basically the Dabigatran, it can bind to that and ta-da. Looking at some of the pharmacokinetic and pharmacodynamic parameters, dosing is obviously going to be a big question we need to know. We're going to need to do this pretty quickly if we need to do it. And it's a 5-gram dose total. And that's actually given as 2.5 gram boluses, and it's to be given no more than 15 minutes apart. So they get these 2 doses. It has a half-life that is essentially biphasic. Part of that is due to the fact that it's multi-dosed. And then also, if we're thinking of how it's working within the body and protein binding and thrombin binding, etc. It has a very, very quick onset of action, just like the Kcentra does. It works within minutes when we're looking at most of the studies. And it is also renally eliminated, as the drug is. Just a fun fact. I also think this was pretty interesting. Most of the studies suggest that it has about a 350 times higher affinity for Dabigatran than Dabigatran's affinity for thrombin. So 350 times is pretty big. And again, I wouldn't be a pharmacist if I didn't point out how much this is going to cost us. So roughly for a 5-gram dose, it's going to run just over $4,000 for this. So again, something to keep in mind. Some of the literature for this, we have the reverse AD study. We have preliminary results from this of the first 90 patients that they reviewed. Of the total expected 300 patients to be enrolled. This was multi-center prospective cohort study, and it would have been unethical to have given this drug to some patients and not to others, so there was no randomization or placebo arm in this. They looked at 2 groups. Group A had about 51 patients that had overt life-threatening bleeds. B was 39 patients that were experiencing a need for a procedure or urgent surgery. Primary endpoint, again, we're just looking at laboratory values. So we're looking at the ability for the drug to neutralize Dabigatran's action within the body. We didn't really look at patient parameters specifically. So they drew the thrombin time and the ECT at baseline between vials, 10 to 30 minutes after the second vial, and then 4 hours later. So some of our dosing strategies come from this, as well as the phase 1 and 2 trials. So just to make things a little bit more confusing, we had to do all of this. Full results of this study are expected in 2017, but primarily, yeah.
Yeah, I was just going to say that was very, very well presented, and the reason, the ethical dilemma, or why it was ethically not okay just to do double-blind randomized, is because this is not new to Europe. So this is something that's been around in Europe, and they've been using, and so it does have a proven track record in Europe. It's just that the FDA tends to have more hoops to hop through, and
I gotta make it more difficult.
Yeah. So that it has been shown to be of at least some benefit in Europe, and hence the ethical issue.
So when we looked at the lab values, essentially the primary endpoints showed that all of these laboratory values did decrease as we would expect them to. I could have shown you the exact numbers that the thrombin time and the ECT changed from, but again, wouldn't really make much sense because we really don't know on our end what that means in a patient because we can't get those labs. Essentially though, they all decreased, and it was shown that this can actually work to pretty much negate Dabigatran's anti-coags within the patient. So when we looked at some of the secondary outcomes, they also looked at unbound or the free dabigatran. As you would expect, it also decreased. And then there were some investigator-reported things to consider. So the median investigator-reported time to cessation of bleeding in those patients that were experiencing bleeding was about 11.5 hours. And then when looking at the patients who were taken to surgery, only 36 of the patients actually underwent surgery, and 92% of those patients, their surgeons documented that they had normal intraoperative bleeding. So your normal and your normal might not be the same, but that was how it was presented. So take that for what it's worth. There were some issues, obviously, as we would expect in this patient population alone. There were 9 deaths in each group. 10 total deaths were due to vascular causes. 5 of these were also fatal bleeds, but 9 of the deaths total did occur about 96 hours after the treatment with it, and they're said to have been associated with the index event and not necessarily due to the reversal of this. There were 5 patients who experienced non-fatal thrombotic events. So they had some bleeding. This was also, per the authors, supposedly due to the fact that the patient wasn't on their anticoagulant. And again, they're saying it's not because of the drug. I caution you, obviously we all know that reversal is definitely going to be a touchy subject with things. We have to take all of the risk and benefit with it. So there's definitely going to be risks of thrombosis in these patients, just taking them off their medication, but then also giving them something to reverse its effects quickly. So overall, the conclusions that we can kind of draw from this, it definitely looks like Praxbine might be effective at mitigating the anti-coag effects of the drug, and supposedly the deaths are due to omission of the original drug. We talked about this a little bit already. The labs that they looked at, we can't really utilize in patients today, so I'm not sure how helpful that would be for us. And the main thing that I draw from this is it might be an option, and it's something that we can use if we need to, but there are definitely other things to consider before throwing this, almost $4,000 or $5,000 drug at someone that could potentially harm them even further. So looking at when they last took their dose based on their age and renal function, do we even need to reverse them if they took it 20 hours ago and they're a relatively healthy adult? So just some things to keep in mind here. Some other things that have been looked at in some of these agents, activated charcoal. We use this all the time in the ER for suspected overdoses, etc. It works by decreasing GI absorption, so if the patient can't absorb their drug, hopefully then it won't work. In 2014, Wang and colleagues were one of the many other groups that had looked at this as a possible option. And what they initially looked at the plasma concentration of Apixaban, whether it was given alone, whether it was given with charcoal given 2 hours after the dose or 6 hours after the dose. And if you look at the large graph over here, doesn't really look like anything different. But if you zoom in a little bit, you can see if it was given at the 2-hour post-dose range, there's potential for less of the drug to be absorbed, as you can see with the line with the squares on it. So something to consider. Overall, activated charcoal, patients don't tolerate it super well, but fairly benign aside from that. And again, it's given pretty frequently. So that's an option. And we also look, I talked a ton about protein binding and renal excretion of these medications. So that was because dabigatran was significantly renally excreted and not significantly protein bound. So in 2013, and again, various other studies leading up to this instance, but I think this depicts a little bit of kind of what I'm getting at. Dabigatran, it seems like the ideal medication to maybe potentially dialyze off of a person. And so what they showed here was that with one dialysis session over here, the level of the dabigatran within the body dropped by about 50%. So maybe it was completed right after the patient was taking it, etc. But overall, it's a potential option if we don't have anything else to work with. Unfortunately, the other 3 agents aren't really likely to be that dialyzable based on their protein binding and their renal excretion. So our current recommendations are such that The chest guidelines were updated in 2012, and this time they decided to give us a little bit more guidance. So if we're looking over here, if we have any patient with any major bleeding, so GI bleeds, head bleeds, etc., something that could be very life-threatening, that they're finally telling us that warfarin and the 4-factor PCC or Kcentra are actually recommended over FFP. One thing I will say about this is that there are definitely going to be scenarios where patients are going to get blood products no matter what. So that's something to keep in mind, because there's really nothing telling us if they're getting blood products already and they need these blood products, how safe is it to give Kcentra? There's nothing to tell us that it's not safe, but in my opinion, it kind of seems like you might be throwing fuel on the fire for a clot, potentially, but it's still something to consider. Just keeping all of that in mind when you're weighing your risk and benefit. Unfortunately, there's really no guideline out there right now for what to do when someone's on warfarin and you need to rush them to surgery or anything like that. So again, I give you the options here, and I don't necessarily have one recommendation over the other. I think a lot of it is going to be completely patient specific. So I didn't tell you anything to do about when a patient comes in that's on one of these direct acting agents. Well, unfortunately, that's because there really aren't any recommendations out just yet. Apixaban or Idarucizumab just came to market a few months ago, so nothing has been updated so far. So I put this together and I've updated it a few times over the last few months with some additions. But I think it's important, if you have a patient that comes in and we assume that they have one of these agents on board, I would first want to know which agent we're working with, because of so many differences within these two. So if we think that they might be on one of the 10A inhibitors, I would definitely consider activated charcoal right away if the dose had been potentially given within the last 2 hours. I don't know what else it's going to hurt if we give it and it doesn't work. So if it helps, hopefully, maybe. And then at that point, I would move on to your maybe potentially using a PCC product. Again, there's that limited data for it to potentially be useful at that high dose in patients that are taking these 3 agents, and blood products if need be as well. The other thing to point out here is that Edoxaban is so new, we don't really have a lot of data for this, so we're really just drawing some conclusions on it based on its similarity to the other agents in the same class. Lastly, if we have a patient on Dabigatran, I kind of diverge here. So, thing to point out right now, we do not at our facility have access to Idarucizumab. It's not on formulary, we just don't physically have it. Also, fun fact, I don't think anyone in Shreveport or many of the surrounding areas would have it either. So if it's available, we can consider it, but keeping in mind when the patient last took their dose, their age, renal function, all of those things that really play a role in whether we need to reverse or not. And then finally, if that is not an option, I would start thinking about dialysis right away if we could potentially get the drug off board. I say especially without major bleeding here, mostly because of the time that it will take to get dialysis potentially set up for a patient. Just keeping that in mind, I would start with that before really moving on with the charcoal, but kind of doing them simultaneously at the same time. Again, we could potentially use charcoal if this was a dose given within the last 2 hours. And finally, if all else fails, I guess you could consider your blood products at that point, because we really don't think that anything else, the PCCs really aren't going to work. So that is the Ashley algorithm for reversal at this point. Maybe I'll copyright it. But there is potential in the future. So we look to some of the agents that are coming out, and I apologize if some of this gets really small. My font's got a little crazy on me. We have 2 agents that are in the pipeline. Andexanet alpha, it is a recombinant factor 10A molecule. So in the future, we might have a similar agent to Apixaban that is able to be used for the 10A inhibitors. So Rivaroxaban and Apixaban, they currently have these phase 3 trials, and I say phase 3 because again, it really wasn't looking at patients that were on these agents and looking at them with actual major bleeding and whatnot. It was basically those healthy patients, we gave them the drug, we looked at labs, and their labs got better when we gave them the next drug. So I don't consider them full phase 3 trials because they really didn't show us what they could be used in, or how they could be used in real patients. Edoxaban, there's actually a study that is beginning soon in Japan that will probably be similar to this. The cool thing is that they're currently enrolling in an additional phase 3 trial. It'll be a lot like the trials that got Idarucizumab. It's FDA indication. I assume a lot of them will look mostly at laboratory values, but they will be looking at patients who are taking it that also experience a major bleed. So we expect those results by 2022, which seems like forever away. I suspect they'll probably do preliminary results as well. Another cool one is Aripiprazine. They're marketing it they're speaking about it as a potential for a universal reversal agent. It's a synthetic small molecule, and that's really all I can find about it so far, that potentially could be a reversal or antidote option for the 10A inhibitors and the direct thrombin inhibitors, as well as some of our parenteral agents, such as fondaparinux and low molecular weight heparins. And then there's conflicting data about whether or not it's going to be useful for unfractionated heparin. And I have no idea what molecule they could make that could absolutely work on heparin as well as all of those. So I'm very interested to see more about this as it comes out. But it is way, way down the pipeline. So with that, if anyone has any other questions, I'm here. Thank you for coming. Hopefully everyone learned a little bit of something, maybe. Thank you. We don't have Praxbind. I guess that was the other thing I was going to point out. So we have the ability to enroll in the study, and we have had the ability since essentially day one of the study, and we haven't even, when I last checked, we hadn't even considered enrolling anyone because we hadn't had anyone that actually met criteria, because so few patients are taking Pradaxa at this point that I don't know. I think in the last 2 years or so, I may have seen one patient actually taking Pradaxa, because all of the post-marketing studies that came out that showed the increased upper GI bleeding risks and whatnot with it. So I don't know. Hopefully we don't ever have to use it, but.
There was a patient, old lady, last year, if you remember, who was struck by an SUV on Duty Drive. She came here, she died, she was on Pradaxa.
Oh. Yeah, so we don't have it right now. I don't know if there's anyone looking at adding it, but we haven't been enrolling anyone in the study, so I think that's one of the things that has been holding everyone back, is just the limited use of that drug nowadays. Yes.
I noticed you didn't talk about probably the very first one to come along, which was Argotaban. It was, I think, originally synthesized in Asia, and was one of the very first of these targeted agents. Is that one just completely fallen by the wayside?
It's just not an oral agent. It's actually, its main use today is patients with suspected HIT. So we have a patient on it.
IV and
right.
So it was not.
And so it's only available as an intravenous drug. So no one in the outside world is going to be on it. So I just left it out for now because.
Sure.
I guess maybe moving forward, I don't think they've looked at anything with the Praxbind for it, because you can turn it off.
Another easy mnemonic is, if it's a ban, then it's a 10, and if it's a tran, it's a 2. So the suffix at the end actually tells you what it's working on. I don't know what help that is, but at least trying to write manuscripts, that's helped me stay out of trouble.
Absolutely.
Other questions? Great review.
Thank you.
That was really good.
Thank you.